Welcome to the BEET Pain Podcast, where we learn what actually works for pain relief, staying healthy, and navigating the medical world. I'm your host, Brandon Cope. Do you know what an occupational therapist does? Today, you are going to find out. My guest will teach us about how OTs can help with spinal cord injuries and how you can be prepared in case you ever have that injury. I have her email in the show notes in case you want to contact her. Please enjoy my conversation with Hanna Wagner. Hanna, welcome to the BEET Pain Podcast. Thank you for being on today. I'm especially excited to have you on the show since you're my cousin and you just finished occupational therapy school and are about to take the board exams. Everyone in our family is very proud of you, and I want to share with my listeners some of the really great things that you've been learning. So thanks for having the time and just coming on the show today.
Yeah. Hi, Brandon. Thanks so much for having me. I'm really excited to be here.
Awesome. Well, so for starters, let's just talk a little bit about what is an OT. I mean, what is occupational therapy? For anyone who doesn't know, I think confusion comes from mixing up OTs and PTs. So can you just tell us what the difference is? Like what is an OT?
Absolutely. That's a great question. And first of all, I will say a lot of people also think occupational therapists are job coaches and that we can help you get a job. That's not true. So just putting that out there.
That's funny. I've never thought of that before.
Yeah, I get that one a lot.
That's great.
A lot of people, though, do mix up PTs and OTs, and it's understandable. There are a lot of similarities, a lot of overlaps. But the main difference really is that with occupational therapy, we're coming in to these patients' lives, and we're really helping them through the rehabilitation process with the purpose of regaining their life and regaining their passions. So instead of just coming in and strengthening or doing a rehab exercise program, we're doing rehabilitation with a greater purpose of actually regaining function and regaining the life roles that an individual has lost either through an illness or an injury, whatever disability or deficit has landed them, either in the clinic or the hospital, wherever we're kind of meeting up with them. And we're all about things that are meaningful to our patients. So we take the things that mean a lot to them or that are a big part of their life roles. And that's kind of what drives our rehab. So it's client-centered, patient-centered, very much focused on what motivates them and what drives them to be involved in the therapeutic process. So say there's a young mother who gets into a car accident and she has some broken bones and maybe even a traumatic brain injury of some kind. We're not going to just take her into the gym and put her through some exercises and, to get her stronger. We want to get her back to the roles that being a mother mean to her in her life. So that looks different, obviously, for everybody in their independent roles in their lives. But that's kind of in a nutshell what an occupational therapist does. And as you and I were talking the other day, you made a really great analogy that I would love to share. Physical therapists are great, by the way. I think that the collaboration between physical and occupational therapists is a wonderful relationship. And I don't think that one is better than the other. I think the teamwork is really important between the two. So going back to that analogy, a physical therapist is kind of more like a strengthening coach. We're talking in terms of a sports team, someone trying to get back onto the field. A physical therapist might be in the gym, lifting weights, doing more strengthening. The occupational therapist is more of a technical coach. So if we're talking about baseball, maybe the physical therapist is the strengthening coach that's in there, having them lift weights, running drills, doing all these things. And then the occupational therapist is kind of the coach that's out there on the field, running through the technicalities and the specifics of actually pitching the baseball, body mechanics, safety precautions, things like that.
Yeah, right. And baseball is relevant for our family because a lot of people in our family have played baseball and really like baseball. So that's fresh on our minds for, oftentimes. Yeah, but it's important to understand, occupational therapy. It's funny because the name, like you said at the beginning, that was making me laugh. I haven't thought of it in the sense of somebody getting a job, but job therapy. But it's, it's making sure that people can do their jobs. It's making sure
Right.
that people can do whatever their life is. So, if it's, how do you hold a fork and bring it to your mouth? Or, I mean, different things that you're doing in your life. It's like, okay, can you actually relearn some of these skills or muscle memory or just the stuff that you do every single day? Let's make sure you can live your life again. It's really, really important for people to be able to do. So
Exactly.
it's great that you're doing that kind of work now.
Good. Thanks.
I want to get into some of the ideas people, now that we've laid out the foundation, this is what occupational therapy is. I think most people might recognize occupational therapists as working with autism, because I know
Hmm.
that that's a large portion of occupational therapy is working with that population, but that's not the only population that you work with. I mean, you were giving the example of, maybe a mother who has broken some bones or having some kind of trauma. What else can occupational therapists help people with?
So that's one of my favorite things about occupational therapy. And one of the reasons I'm so excited about this career, because really occupational therapists can kind of work with anyone. And I know that sounds very broad, and it is. So there are occupational therapists right now working in all kinds of different areas, in everything from the emergency room, acute trauma in the ICU, the NICU, the PICU in the hospital, all of those different traumatic, medically based settings. But also, there are occupational therapists who are working with like corporate companies and doing office ergonomics and work hardening programs to get people back to their jobs. So in that sense, we do help sometimes people get back to their jobs. Um, yeah, and then we're also out in the community doing wellness and prevention types of interventions with the community, driving safety. There's a program called Car Fit that a lot of occupational therapists work with that is helping to fit a patient's car that they already have, helping to kind of make the necessary adjustments that'll be most optimal for their condition. And then also driving safety rules a little bit on the road. Driving
That's
specialists
cool.
do, yeah, it
Wow.
is cool. I
That's
mean,
super practical. Wow.
things that people don't think about. And driving rehab specialists do the actual on the road stuff for the most part, but we help outfit people's cars with necessary, adaptations, this, that, and the other. The other neat thing is that we can work with anybody on the age spectrum. I mean, OTs are working with premature born infants in the NICU, and then we're also working with hospice and end of life care. So really, we're working through the entire spectrum of life.
Wow.
It's just such a diverse career. Also, we work with physical disabilities, obviously, as I've been mentioning, but we also work a lot with mental health and wellness. This looks like inpatient psych hospitals or dementia patients, Alzheimer's, pretty much you name it, and we work with it.
Yeah. Wow.
One specific example that I wanted to share with you guys was a stroke patient that I got to work with while I was in school. Our professor had a number of prior patients who would come in and volunteer their time to spend with us as students, which was pretty brave, knowing that, we were a little bit amateur still. And
Mm-hmm.
So these stroke patients came in, and she split us up into groups and had each patient assigned to a group of 4 of us students. And over several weeks, we developed a relationship with our, person that we were working with. We got to know them. We got to know what their passions were, what their interests were, and what their story was, what had happened. So the patient that we were working with, he was a dad in his mid-50s, a husband, and his son was very into baseball, going back to that baseball theme. So this patient of ours, one of the things that was very meaningful to him and that he wanted to be able to do again was to throw a baseball back and forth with his son. Another thing that he really wanted to be able to do was to cook an omelet for his wife. His stroke was probably 5 years ago, and he hadn't been able to make breakfast for his wife, which was something that he loved to do prior to his stroke. And so our professor created the time and space for us during one of our labs to be able to implement these meaningful tasks with these patients. But the interesting part was that these were things that he had not been able to do in the past 5 years. And so we were trying to get creative with, okay, how can we help him to work on these things? How can we adapt the kitchen utensils or the cooking utensils? And how can we get him to hold a ball when his hand is, after a stroke, you have a lot of different movement patterns that are very abnormal and unnatural.
Sure.
And one of them was that his hand and upper extremity, his upper arm, it's a spasticity pattern. And it's a flexion pattern. So your elbow is in a flexed position, your hand is kind of balled up in a fist. And if you can kind of picture that motion, it's almost as if your arm is up in a fisted position up against your breastbone.
Sure.
Not the most functional position.
Yeah, that's hard for baseball.
And for cooking. Yeah. It's hard for any functional activity, really. And he uses a cane on the other hand. So it's not like his other hand is just available for all these activities. So what we started with, and what most OTs would start with a patient with a stroke or with these, they're called flexor synergy patterns, would be preparatory activities, which can include what's called passive range of motion, where the occupational therapist will actually do some soft tissue massage and try to kind of bring that arm out of that flexion pattern. But it takes a long time. You have to really work those muscles and the tissues, and eventually you maybe can get the arm a little bit straighter. But so we did that a little bit with this guy, and eventually, long story short, we were able to fit a smaller ball into his hand, and we're able to play a little bit of toss with him. And he was so excited. It was so fun to be working with him and just seeing his smile as we worked through these things. And then we ended up going into the therapy kitchen in our lab, and we helped him to cook an omelet. And we took pictures of him to send to he asked us to take a picture to send to his wife of him eating the omelet that he'd prepared.
That's awesome.
It was so special. And it just was such a reassurance to me that I'm in the right field. So it was really exciting.
Yeah, that's great. Okay. So, talking about, okay, you're in the right field, the stuff that's really exciting you with all of this different work. You've worked with somebody who had a stroke, but you're planning to start working with people who have spinal cord injuries, right? Post-traumatic spinal injuries. And
yes.
that sounds really intense. I mean, what exactly is that kind of injury? Like, paint a picture for me. Somebody gets a spinal injury, what kind of injury is it that you're working with there?
So that's a good question. A lot of spinal injuries are trauma-based. So whether that's a motor vehicle accident, gunshot and stab wounds, sadly, are actually pretty common causes of spinal cord injuries. Wow. A lot of times falls or diving accidents.
Oh, sure.
But spinal cord injuries can also come from various diseases. They can come from tumors that attach onto the spinal cord. Various types of cancer can cause spinal cord injury. And then also diseases such as ALS, the amyotrophic lateral sclerosis, or Lou Gehrig's disease, and multiple sclerosis. So really, spinal cord injuries can happen from a lot of different causes. And what that looks like, I know we'll get into that a little bit later, but it's pretty traumatic, and usually, almost always, it ends up with some form of paralysis, whether that's your entire body, whether that's one of your limbs, whether that's just your lower body. So it really can take a lot of different shapes and forms, but it's a really traumatizing event that is life-altering.
Yeah, absolutely. Okay. So then you would be working with somebody, I mean, in an ER, like I'm imagining somebody gets into a car accident, they've got a post-traumatic, or they've got their spinal cord injury. They go to the ER at the hospital, and I don't really imagine an OT. When I think of an ER, I think of, the ambulance and the doctor, and there's nurses all around. And I don't really think of wait a minute, where's the occupational therapist? So, I mean, what does that look like for an occupational therapist to be working with somebody in a hospital or at the ER like that?
Yeah, good question. That's kind of an emerging field right now. I think that a lot of people in the medical field are recognizing and realizing the importance of early intervention and intervening as close to the traumatic event as possible in order to retain the most function after the incident, if that makes sense.
Yeah.
So a lot of ERs, I think, still do not have occupational and physical therapists, but as I said, it's becoming more of an emerging thing. So one of the roles that an OT would play in the ER, sometimes in a case of a traumatic event like a fall or maybe a minor stroke, things like that, not so much a spinal cord injury, but for smaller scale things, sometimes the occupational therapist will come in to like identify and then assess the patient or do like a little evaluation to see if the patient might be able to go directly home instead of actually getting admitted to the hospital.
Okay.
And that's kind of just to go over safety guidelines with them, just to sort of see what their functional limitations are. And again, to go over safety awareness and helping to identify if they're not going to go straight home, but they're also not going to get admitted into the hospital. Sometimes an OT can help identify an alternative placement that would be maybe most appropriate for this patient. And since we're such a big part of the rehab process, after surgery or after the doctors have intervened, I think it's becoming more and more important that we are part of the kind of the assessment team that decides, where they should go. Are they safe to go home? But in the case of a spinal cord injury or something a little bit more serious like that, I think an OT's role in the ER, it varies obviously depending on injury or illness or deficit.
Sure.
But with a spinal cord injury, one of the things, this could happen in ER, it could happen very early on once they've been admitted into the acute care, is that you perform various assessments to find out what level the spinal cord trauma was at, and then what type of sensory distributions they have remaining after the incident. And what I mean by that is there's various tests using different textures of materials or like a pointy or a blunt end, and you go up every dermatome of the body. So you go up the body basically an inch at a time to see if there's a reaction to that stimulus in order to kind of map out what sensory feelings and impulses they still have left. And one thing that can complicate that is spinal shock. And I know that we will probably talk about that a little bit more later, but often people have a period of spinal shock that can last from 24 hours to 6 weeks after a spinal cord injury. And sometimes it's kind of difficult until that spinal shock wears off to get a true sense of the person's actual deficits, because spinal shock causes a temporary loss or decrease of either all or most spinal reflex activity below the lesion or below the spinal cord injury location.
Okay.
And this is still something that's a little bit poorly understood, but it's really important that it happens fairly early on if possible.
Yeah. Okay. So that mapping, okay. So you're looking for dermatones, and the dermatones, if people don't know what that is, that's the mapping of where the sensation of nerves goes throughout the rest of the body from the spinal cord. So, I'm assuming that you're kind of tapping through there looking, okay, what part of the spinal cord do you feel? Do you not feel? You're kind of, you're doing tapping. What else did you say? Where you were tapping people, but you're doing other things too, right?
Yeah. So you'll use the different mediums like a cotton ball or like a little monofilament that's like almost like the end of a mechanical pencil, like the lead, it's a really fine thing. So you'll do different sensation tests. And it's important to note too, for people who might not understand dermatomes as well, that we're not doing this actually on the spinal cord on the back. We're doing it on the fingers and, up the arm and down the legs, because that's where all the nerve distributions that come from the spinal cord end up.
Right. Okay. So just run me through here, God forbid that I have an accident and I need your care, and, what should I prepare for? All right. So I might go into spinal shock. You're going to be doing some sensation stuff. I mean, what else might I need to know if I were to suddenly have a spinal cord injury?
Good question. Heaven forbid that ever happens. It really depends on the location of the lesion or the injury. So your spine is broken up into 5 different sections. You know, we've got your neck area is the cervical spine, and then we've got the thoracic spine, which is most of your upper back, which leads into your lumbar spine, and then your sacral and coccyx areas. These all look so different. They all present so differently when it comes to spinal cord injuries. Obviously, the most severe is if you have an injury to your cervical spine or your neck area. This looks, even within your cervical spine, it can look really different. If you have an injury from vertebra 1 to 4, it affects the musculature of your diaphragm.
Okay,
so for those kinds of patients, they're going to be on a ventilator. They can't breathe on their own. Occasionally, somebody with a C4 injury can come off of the ventilator and breathe on their own. But initially, at least, they're definitely on that ventilator.
Okay.
Once we get to a C5, there's a little bit more arm movement. With C1 through C4, you have neck and head movement, and that's it. Sometimes a little bit of shoulder movement. And then as we move down the spine, all the way down to the sacral coccyx area, there's more and more return that you get, basically. The kind of crazy thing is that all the way up to a C6, you can actually drive a car.
Wow,
and
that's crazy.
Yeah, it's pretty crazy the way that they can adapt the controls. You can control the car with your hands, and it's pretty neat. But anyway, sorry, I'm getting sidetracked here.
No, that's cool.
Back to your original question. Like you said, you'll expect some spinal shock. It doesn't happen in everybody. And those that it does happen in, it's not a good sign. Even though it wears off, quote unquote, wears off, usually the outcomes of therapy are less successful for those that have experienced some form of spinal shock.
Yeah.
Like I said, it depends where the lesion is on your back. It also depends what type of lesion you have. So you can have what's called a complete lesion or an incomplete lesion. If you have a complete lesion, that's a complete severance of your spinal cord. And technically, the diagnosis is that you have no motor or sensory function or sensation below that level. An incomplete injury, there's the possibility that you'll still have some return of those functions below the level of the lesion. So it's important to determine what kind of lesion it is, incomplete or complete. And then a huge part of spinal cord injury, obviously, is just the psychological and mental stress that this is going to put on an individual. A spinal cord injury is life-altering, and as of where we stand right now, it's mostly irreversible. So I think mentally and psychologically kind of preparing for the fact that people are going to have to help you, at least in the initial stages, until you can learn some more strategic and adaptive and compensatory strategies. I think that it's really important to remember that people are there for the purpose of helping you, and just kind of recognizing that you're going to need that in the beginning.
Yeah, that's big. That's really hard. That's really hard to go from a point of I'm totally independent. I can do things all on my own. I can drive. I'm playing sports. I'm, getting my own groceries or going to the bathroom by myself. I mean, it's like, it's such small little things that you almost don't even think about. It's just your daily routine. You don't give it a second thought. And then it's like, if you were to get a spinal cord injury, those kinds of things would be so difficult and time consuming, and you've got to learn a whole new set of skills, and people got to help you with stuff. It's those little things that oftentimes we can take for granted. And that's the kind of stuff that you're helping people with, when they have those spinal cord injuries. You're like helping people get their dignity back, get their life back, helping people become independent, learning all those skills. And that's awesome. Anyway, so keep running me through the scenario though. I mean, okay, all right. So I'm, theoretically I was, in my crazy motocross, skydiving injury, whatever I did to myself. And I've gone through all these different things, and, now I'm in the home trying to relearn things. I mean, what else should I be prepared for?
So some other things to be prepared for are, along with people helping you, one of the biggest areas people are going to have to help you with, at least initially, is your bowel and bladder control. And the good news is there are lots of different programs out there that can help in regulating those functions for you. So, I think one of the cool things about OT is that we're helping people not just to get back all the functions that they lost, which is called restorative therapy. But if that's not possible, as is the case in a lot of spinal cord injuries, we're also in the business of compensatory therapy and adaptive therapy. So, just because you've lost all sensation of the lower half of your body, and you maybe don't know that you need to use the bathroom, you can get on a routine and a schedule, and OTs can help with that with the help of these programs that have been established. And you can self-catheterize, and you can be on a schedule where you know that you need to, take your wheelchair and go into the restroom. And
Right.
so in that sense, you can become independent in that. Again, it just is a different type of independence. We call it modified independent. So I love that the word modified independent still has the word independent in it, because, this person, it looks a lot different, but he or she can still be independent in their bathroom self-care, things like
Yeah.
that.
Yeah, totally.
That's a big realm for occupational therapists to work in. And then you've got the issue of mobility. Again, just because your legs maybe don't function the way that they used to doesn't mean that you can't get from point A to point B independently. You can, a lot of times, if it's a lower C-spine injury or an upper thoracic spine injury, you're going to be able to have your control of your mobility, whether that's in a manual wheelchair or a powered wheelchair. And depending on how high up the lesion goes, there's all kinds of different accessories that can be fitted to a wheelchair. So if you don't have any control over your trunk or your arms, they can put on lateral side supports on your wheelchair so that you can
Okay.
sit up on your own. If you don't have much neck control, they can help by putting headrests on either side, or even in some severe cases, a forehead strap to help you keep your head up so that you can look at your peers and look at the world around you without
Right.
being slumped forward.
Right.
Another important thing is going to be passive range of motion. So if you've lost range of motion in your arms and legs, and they're just sitting there in a bent position all day, you're going to develop muscle contractures, which is the shortening of muscles. And they become very rigid, and it's really hard to straighten them again once that rigidity takes place and those contractures settle in. So it's really important as occupational therapists that we not only perform those passive range of motion exercises in the hospital and in the clinic, but that we train caregivers and family members on how to do that when the patient goes home. A lot of occupational therapy is caregiver education, as well as, we'll perform the activities and do the various treatments when the patient is with us. But once they go home, a lot of them will get some home health services. But once that's over, a lot of these people, this is a lifelong thing. So you're going to have to train the caregivers on how to do home care once the initial set of therapists and doctors and stuff is has discharged the patient. So
Right.
caregiver education is important.
Right.
And then going back to wheelchairs, something else that's really important in wheelchairs and beds is the type of cushion or mattress that's used. And this is because since a lot of these people are fairly immobile and sedentary, they can develop what are called okay, just scratch that. Bed sores. Bed sores.
Yeah, bed sores. We got it.
I can't say the word. And so you have to develop a plan for what type of material and cushioning they're going to be on, because since they're on it all day. If they have a cervical spine level 7 lesion or lower, they can perform independent weight shifting, because they can push up onto the arms of their wheelchair using their upper body strength, their arm strength. But if it's a lesion higher than that, then they're not going to be able to do that. And so again, the caregiver is going to have to shift them, and it's really important about every 30 minutes to an hour that they're weight shifting so that those pressure sores don't form.
Mm-hmm.
And different materials in terms of wheelchair cushions can be anything from foam to gel to air. the air filled ones are the best for the pressure ulcers, but they also lack stability. So you kind of just have to get to know your patient and see what type of cushion is going to work best for them and what type of mattress. They also have air mattress type things to prevent those pressure ulcers. And then another type of wheelchair that I wanted to mention is for an extremely high level spinal cord injury. These people don't even have the ability to use their hands. So they can't use a joystick to push forward their motorized wheelchair or their power chair. So we have what's called a sip and puff system. Sip and puff, yeah.
Okay.
So what this is it's a high-backed wheelchair because they don't have control over their upper body. And if you ever see this out in the community and you see somebody that has almost like a little straw pointing that comes off of their headrest and comes towards their mouth, what it is that in order to move your wheelchair and stop your wheelchair, you simply use breath control. And it's pretty cool. But like I said, some of these people are still on ventilators. So it gets a little bit tricky when you have a ventilator and a sip and puff wheelchair, but it's possible. It's very possible,
that's a lot of technology.
It is. And it's pretty neat. I mean, these people have control of hardly anything else in their life, but they can move their wheelchair forward and stop when they want to, which essentially kind of gives them, the ability if they want to, go for a little walk. Obviously, they probably wouldn't be left alone by their caregiver, but they have the independence to move themselves along instead of having to be pushed by somebody else. So how it works is that they will put their mouth around the little straw and either inhale or exhale, and it'll get the wheelchair started moving. When they want to stop, if they have, breathed into it to make it go, then they'll inhale to make it stop.
Wow.
So it's a pretty cool technology that's, allowing a little bit more independence where before there was none.
Yeah, that's incredible. Yeah.
It's pretty crazy. They're coming up with all kinds of things like this, which is really exciting. Another form of independence for people, again, with more the middle back spinal cord injuries, thoracic or lower, is a sliding board. It's basically a sanded down piece of wood, kind of looks like a 2x4, a little bit thicker.
Okay.
And they're able to kind of hoist up one leg, stick that sliding board under their backside, and then use their upper body strength to transfer to the bed or to the therapy mat. So again, it gives them a sense of independence and getting from their wheelchair out of it. One example of this, actually, we had another guy come to our lab one day, another patient, and he had been in a car accident and gotten a thoracic spinal cord injury, and was unable to walk, and everything below that lesion, because it was complete lesion, didn't work. But he showed us, he took off the arm of his wheelchair, stuck the sliding board into his wheelchair, and then he slid over to the therapy mat. And, looking at him doing all that, you wouldn't have thought he had a spinal cord injury because he just looked very independent.
That's great.
Another part of that was that he goes to the gym and works out a lot. So, which is also important. He was keeping his upper body strength really prime so that he could do things like that and kind of maintain that independence.
Yeah. Totally. That's awesome. So, that's great how much independence you can give to somebody after they've had, even a really high upper cervical injury. They couldn't move their arms or legs, but they could just do something with their mouth. They could do a little breathing that is so cool that we, whatever little movement is still available, we can capitalize on that and give somebody independence through even that small movement. That's such incredible technology. But I want to talk a little bit about some of the different aspects of somebody having a spinal cord injury here. If somebody's lost the ability to use their legs or their arms or control bowel movements, that can dramatically affect their psychosocial health and behaviors and their identity. And how important is it for somebody to get psychological therapy for spinal injuries? And, do you as an occupational therapist, in working with somebody and knowing the psychological toll that's being put on people, the burdens, I mean, how does that influence your work with people? What are some of the needs in that area? What are your thoughts on that?
It's extremely important. That's one aspect. Mental health and the psychosocial, dealing with with physical disabilities. That's a huge part of what we are trained in school. We are taught, and it makes sense, that psychosocial counseling needs to be basically a really big part of our journey with every patient. And that's because every patient that comes to see us, they're all there for a reason. So they've all either had some sort of disability or injury or illness or deficit that's causing them to have like a lack of what's important in their life, So if they're visiting us, there's a reason for that. And so
Mm-hmm.
we're dealing with a vulnerable population. Obviously, some are more vulnerable than others. A spinal cord injury, like we've talked about, is huge. It's life altering, and really just changes everything for you. And so a lot of times with that can come depression, which is very understandable.
Yeah.
You can go through various stages of grief and anger. At the end of the day, though, you're still where you are, if that makes sense.
Mm.
It's important to express those feelings. And as an occupational therapist, for us, when our patients do express them, it's extremely important for us to acknowledge them
Yeah.
and not to just say, and sometimes just being encouraging, that's not what they need. Sometimes they need somebody who's going to actively listen to them and who's going to repeat back what they hear the patient saying, in order to make sure that we as the occupational therapist understand, and that we can be just the best mental, psychological support that we can for them.
Sure.
But it really is important in every aspect of therapy, whether you're coming out of a total hip replacement, or if you took a fall and broke your wrist. It's just, all of these things take you away from the roles and functions of your daily life.
Yeah.
And so I think that the mental health care of these people it's vital. And one of the things, and as actually also for their caregivers, because the caregivers are also suddenly impacted with, maybe a woman falls down and breaks her arm, and they have 2 kids and the husband works full time. Well, now he has to take on some more roles that he wasn't prepared for. So really
Mm-hmm.
there's mental health and psychosocial counseling that really needs to go into the whole family,
Yeah.
caregivers, loved ones, relatives, especially in the case of something like a spinal cord injury that
Yeah.
changes not only the patient's life, but everyone around them. And so we do a lot of different stress relief techniques, a lot of deep breathing,
Mm-hmm.
and then even things like a lot of sleep and leisure checklist type things, because those things affect your psychosocial well-being just as much. If you're not getting enough sleep, you're going to be
Yeah.
agitated. You're not going to be as successful.
Yeah.
And if you're not engaging in leisure tasks, you're also probably going to be a little bit more agitated. And so we do a lot of coping strategies, like I said, relaxation, progressive muscle relaxation, which is you go through like a guided imagery with the patient, usually laying down,
Okay.
and doing, with music, and there's just a lot of different ways that we can implement that psychosocial element of care. And it's
Sure.
really important that we do it with pretty much everyone.
Yeah. It's really, I mean, it's a very personal space with somebody, I mean,
Very.
you are getting into their life. You're in their business, you know what's going on with them emotionally, physically, their struggles, the hardships. I mean, you're
Mm-hmm.
right in that space in their life with their family and everybody around them.
Yeah.
And, and it makes me kind of wonder for you, like, you personally, why did you want to start getting into spinal cord injuries? I mean, why not go with something different? Why not work with something else? Like, why specifically did you have an interest in working with these types of injuries?
Yeah. So that's a great thing to bring up. Several years back, I was already interested in the occupational therapy career. But over the course of 2 years, 2 of my dad's best friends both got into separate biking accidents and ended up in the hospital, ER hospital, and then both ended up in a rehabilitation hospital. And just hearing their experiences of both having these various levels of spinal cord injury, and not just being really uncertain about the future and being in that really vulnerable place, hearing their experiences with their rehab team and with their occupational therapists in particular, it really just touched something deep inside of me. And I thought that is what I want to do. Those are the kinds of people that I want to help. I mean, these are both middle-aged, like fairly young men who are both fathers and who have both had these just catastrophic events happen to them. Yeah. And I know that they both dealt with a lot of emotions through the whole thing. They both worked really hard, and by the grace of God, they're both walking. One of them's walking with a walking stick, but they're both walking. They're both able-bodied in terms of being functional.
Yeah.
But just hearing their experiences and thinking through the process that they went through, and it just kind of made me realize too that in order to be an occupational therapist in any setting, but particularly in this setting, working with very vulnerable, perfectly healthy previously adults that have gone through such trauma, you have to understand that they're going to be embarrassed probably, and their dignity when you're helping them in the bathroom, and it's hard to explain, but I felt really connected to their stories, and I thought I want to be a part of that, and I want to be a part of helping these people regain their function and kind of getting their lives back.
Yeah, absolutely. I remember when your dad was kind of sharing the stories about those two friends and the experience, the horrible injuries that they had. And I mean, I told you this before, but I'll repeat it. I remember seeing one of the friends at a church service, and there's that time where everybody gets up and shakes hands and, greet somebody next to you. And so I would, he was sitting right in front of me, and he turned around and he remembered me. Hey, Brandon, how's it going? And, he kind of knew a little bit of the work that I do therapy with people. And I was kind of asking him about his injury and stuff. And he just, when he shook my hand, he just kind of gave me this look and I so appreciate the work that you do. He just looked me in the eye and was so sincere. And it just struck me like, wow, he like, this is like really meaning. Like, he's never been in my office. I've never worked with him before, but he just like understands the effects of having to work with somebody who does this kind of therapy and doing this rehab. And he just kind of paused for a second. I almost thought he was going to like cry right there in the moment or something. But, it's really life-giving. It's really life-giving for people when they get to work with somebody who helps them regain their function, their independence, their, all those things in their life that they get to do again. And they don't have that horrible fear deep down inside that's like, I don't know what my life is going to be. All these terrible things are going to happen. It's like, you've got somebody with you. This person's going to help you confront those fears and work through that with you. That's so life-giving for people. And so,
it is.
That's great that you've been able to see that. And, you want to make your work and your career be something that is giving so much to these people who have gone through these, horrible experiences and injuries and things like that.
Yeah.
So that's awesome to hear that.
Yeah,
Well,
thanks.
Yeah. Let's talk about what you hope for in the future of spinal injuries. We've talked a lot about what's happening right now. You've shared some cool stuff with technology, some stuff with, how wheelchairs work and the sip and puff and some really cool stuff like that. I mean, what are you thinking that needs to happen in the future, or that you're excited or you're hoping for in the future with your kind of work?
Yeah. So some of the things that I'm hoping, hopefully I'll get to work with the spinal cord population. That's the hope. That's the dream. And some of the things that we're seeing right now in medical science and medical technology are specifically aimed at spinal cord injuries. And so as the field grows and as I hopefully become a part of that, I'm really excited to see more technology being implemented in the recovery of these patients. And those technologies look really different, but they're doing things right now, from exoskeletons that are helping people relearn how to walk and regain that kind of mobility. These are still all in the very early phases, but that's why I'm so excited to be kind of coming into this right now. It's such an exciting time. So these exoskeletons that are helping people with their mobility, standing frames have been around for a long time, but even working with these patients who have been, sedentary and immobile for so long, and helping them to just be able to stand up in a moving standing frame.
Yeah.
And then they're doing crazy cool things right now. Things like epidural stimulators, where they're actually like implanting these devices in people's spinal cords, and seeing people walk again. I mean, they're all still in the experimental trial phases of this, but seeing that these things are happening and that they are possible, it gives me so much hope and is so encouraging for me to be hopefully entering into a field that we've only just begun to scratch the surface of what's going to be possible for these people. And so I'm really looking forward to being a part of that, and to hopefully helping to grow those technological advances. Well, I won't be on the tech side, but the implementation of those devices with patients, and just seeing the life that they can kind of give back to people. There's just all kinds of technology. They're even doing like cell relocation in the body, relocating cells from one place in your body to another place in your body to hopefully try and regenerate some of the nerves. And so it's a very exciting time to be in the business of occupational therapy and in the health field in general. I mean, as you understand with all the stuff you're doing as well.
Yeah. Yeah. Well, I love it. There's great stuff going on, and it's life-giving, spreading hope, encouraging people, helping them with all the work that they're doing in their lives, and getting people back into, function and health. And, it's great work, and I'm glad that we're both doing it. For anybody listening to this right now who might be thinking, okay, I know somebody with a spinal cord injury, or I have a spinal cord injury, and what are more things I need to learn? How do I research all of this stuff? Can you point them in any kind of direction? I mean, what resources are out there? What are things that you would encourage people to be reading up on or learning so they can know more about all the things that we talked on today?
Sure. So some of my one of my favorite mediums of learning is through TED Talks. And that's something that we learned from a lot in school. And a couple of TED Talks that I just want to point out, if this is something that you're interested in or want to learn more about. The first one is regarding neuroplasticity, which is, we didn't really talk about that much, but it's kind of, it's a relearning and a regrowing of neurons in the brain in order to produce new movements after a deficit. Or actually anybody can do it, but it's particularly helpful and interesting after some kind of trauma to the brain or to the central nervous system. So that one is called neuroplasticity after brain injury. So that's a little different than we were talking about, but it talks about neuroplasticity. And that's a TED Talk by Dr. Sean Phipps, who's a chief quality officer and associate hospital administrator at Rancho Los Amigos, which is a national rehab center. Yeah, it's down here in Southern California.
Yeah,
and then he's also an occupational therapist and has been for over 20 years. So check that one out. That's a really interesting talk.
Yeah. And with neuroplasticity, I mean, that is a really exciting field that people should be exploring, because that's been growing, and there's more research and books and things that are getting written and explored with all of that. And for people who have a spinal cord injury, yeah, you're right. We didn't talk too much about that, but you totally should be checking out, what is neuroplasticity? Why is that relevant to me? How can I get involved in that? Absolutely. You're on the right track with that.
Yeah, great. Another TED Talk that I really enjoyed listening to is called Creating Our Future with Spinal Cord Injury Therapy. It's by a man named Professor James St. John, and it's developing different ideas about cell transplant, like I was saying, from other parts of a person's body into the into the affected parts of the body. This is all still very emerging, like I said, and it's all still in the trial phases. But they're hoping, I believe, by the year 2030 to have some more of these things well established. And even this year, this TED Talk was in 2018, and he talks about by the year 2020 with one particular patient that they're hoping to move forward with some intervention for him. So check that one out. That's also a really interesting one.
Okay.
And then the third and final TED Talk is regarding that epidural stimulator that I was talking about earlier. And this one, the lady who gave the talk is actually from here, Southern California, in Manhattan Beach. Her name is Susan Harkema, and her TED Talk is called "How Paralyzed People Are Learning to Walk."
Ooh,
and
that sounds exciting.
It's pretty interesting. They have two patients that they've been working with. One was in a mountain biking accident. One was in a truck accident. She rolled her truck. And they're both young, 20s and 30s. The young woman is 22 and the young man is 35. And it actually shows videos of these two people who are completely paralyzed. It shows both of them walking.
Wow.
So I would highly encourage watching that one. So those are a couple of TED Talks. And then in the greater scheme of occupational therapy, kind of veering off of just spinal cord injury, I'm reading a book right now called The Chicken Who Saved Us, which sounds really funny.
That's a great name. Yeah.
It's by Kristen Jarvis Adams, and it's all about a family dealing with their young boy who has high functioning autism, which used to be called Asperger's, but now it's considered part of autism. And it's about this chicken that's part of their family, and it just is a really interesting look into the life of a family with an autistic child. And it just gives a really good understanding and picture. If you have anyone in your life who has a child with autism, I feel like this book will help you understand just the difficulty that can bring, and maybe could lead to some sensitivity, for our population to understand what some of these families go through. We see them out in public, perseverating on something or having a fit, and we kind of are judgmental sometimes. And I think it's so important to understand that these families didn't ask for that, and yet they love these children so much. And I don't know, this book, I think it can help us to learn how to love them too.
Yeah, that's great.
And then one other resource that I'll share with you is a movie that I watched for OT school, actually. It's called The Fundamentals of Caring. It's about a client who has muscular dystrophy. So it's not a spinal cord injury. However, obviously, well, like I said earlier, it's a type of spinal cord injury. It's just not from a trauma. So it's this teenager who's in a wheelchair, and it's the whole movie. It's a little rough around the edges, but it's this whole relationship between this new caregiver who's never worked with somebody in a wheelchair, working with this guy who has this disease. And it's a really beautiful depiction of their story and the difficulties, and it's funny and it's sad, and it's really, really raw and really real. It shows the anger that the kid goes through, and it shows the struggle of the caregiver not knowing what to do and helping the kid use the bathroom. It's a great picture of what life looks like for not only the patient, but also for the caregiver. So yeah, those are a couple of little resources that I have found to be interesting and helpful and exciting.
Yeah, that's great. That's really great stuff. That's a lot, and that's really awesome for people to be able to go through those and learn that. Thanks for sharing all those resources.
Oh, my pleasure.
And thanks for just taking us step by step through understanding a spinal cord injury, what's going to happen, what people should expect. I mean, you've given us a lot of detail into understanding the mechanics, the dynamics of everything that goes into that. So for somebody who is in that situation listening to this, I hope that you've gotten some really great tools and a really great, helpful understanding of what you need to be doing and what can be, useful for you. Or if you know somebody who has a spinal cord injury and you're considering, okay, what kind of, treatments, what kind of things do I need to help this person? I hope that we've provided some really great information for you listening. But Hanna, thank you so much for being on the show today. Thanks for your sharing and your details and your experiences and your stories. And, I'm just really excited for you as you're, taking board exams and getting into your career with occupational therapy. I know that you're super passionate about it. You're really smart. You're going to help a lot of people. And I know that it's going to be life-giving, not only for you, but for everybody that you work with. So I appreciate you being on the show today. Thank you.
Thank you so much for having me. It's been great talking with you, and looking forward to getting into it.
Thanks for listening to this episode with Hanna. If you want to be involved with the podcast, there are 2 ways for you to do that. First, if you have any questions you want answered or topics you want us to talk about, then click on the BEET Pain website link in the show notes and message me. Second, if you want to continue listening to great content and guests, then I need your help to build the podcast and get those guests on the show. The bigger the podcast gets, the easier it is for me to bring on more guests. Subscribing, writing a review, and sharing this with others helps this show to expand. Thanks so much for listening.